this week on the BackTable Podcast.
There was a long period of time where local therapy did not matter because the survival of patients was very short after the development of spinal column metastases. However, with the development of novel systemic therapy agents and specifically immunotherapeutic agents in many disease sites, survival has increased quite significantly in these patients. And I think the spine oncology program has really been a recognition of the fact that, if a patient is in incredible pain or incredible neurologic compromise, they cannot go and get the systemic therapy that will ultimately prolong their life. And in addition to that, if patients are living longer and longer and longer, functional outcomes that may have been acceptable in a patient with a survival of 3 months are no longer seen as acceptable in patients that may have survival of 3 years or longer from the time that they presented.
Howdy, everybody, and welcome to BackTable Podcast from currently cloudy Connecticut. My name is Alexa Levey, and I'm an interventional radiologist from Yale School of Medicine. Today, we have a very special episode discussing multidisciplinary approach to treatment of spinal tumors with Drs. Mark Amsbaugh and Drs. Lador. Dr. Mark Amsbaugh is a radiation oncologist at the University of Texas McGovern Medical School, where he serves as an associate professor of neurosurgery, the co-director of gamma knife and stereotactic radiosurgery, and the medical director of the Memorial Hermann Texas Medical Center Radiation Oncology Clinic. Dr. Amsbaugh received his medical degree at the University of Texas Medical School, completed his internship at the University of Connecticut St. Vincent Hospital, residency training at James Graham Brown Cancer Center at the University of Louisville, before completing his fellowship at the University of Texas MD Anderson Cancer Center. And Dr. Lador is a spine surgeon at the University of Texas McGovern Medical School and serves as an associate professor of orthopedic surgery. He is the chief of spine oncology and minimally invasive spine surgery at the Orthopedic Spine Division. He is a founding member of the Spine Therapy Society, which promotes a multidisciplinary approach to spine oncology care. He received his medical degree from the Hadassah School of Medicine at the Hebrew University of Jerusalem, completed his orthopedic surgery residency at Tel Aviv Sourosky Medical Center, affiliated with the Tel Aviv Medical School, and subsequently pursued advanced fellowship training in spine surgery and spine oncology at the Rizzoli Institute in Bologna, Italy, and later neurosurgical spine oncology at the University of Texas MD Anderson Cancer Center. Thank you guys so much for being here. Welcome.
Thanks, Alexa. It's great to be here.
Great to be here.
So why don't we start off with telling us where you guys are at, what your practice looks like, and how does it differ from others in your field with regards to spine tumors and spinal pathology? We'll start first with you, Ran.
Both Mark and I work at University of Texas Memorial Hermann in Houston, and we set up a goal of establishing and creating a cohesive multidisciplinary tumor program in Houston. We have a huge referral center and a base of patients obviously needing and unfortunately suffering from spine tumors. And getting treatment in a very cohesive way was a challenge. And so we worked real hard in the past several years to create a program where we join forces and treat those patients. The nice thing about it is we found a friend and we are working together, and it's actually fun. We tease each other, we fight each other, we arm wrestle. I always lose, but it's still a fun thing to do.
And what about you, Mark? How does your practice look and differ from others? And as Rand was saying, why a spinal tumor board?
I think Rand kind of hit it on the head. I think both of our practices are somewhat unique in the country, and I think that starts with both our academic affiliation with University of Texas McGovern. It's a very large medical school here in Houston, which is the third largest city in the country. So the breadth and depth of pathology that comes in because of the academic affiliation with the school is quite large. But in addition to that, we both primarily practice at Memorial Hermann in the Texas Medical Center, which is a quaternary care large referral hospital for both regional, national, and international patients to come in. So I think the number of patients that are seen with varying pathology is quite great. And in addition to working together, we also have the opportunity to work with many very talented, very subspecialized colleagues who are really the best at what they do in the country. So it's been really great to not only have the opportunity to care for such a broad range of patients, but also have, kind of a high number of unique cases that allow us to have experience with really tough things and share the treatment of those patients with truly fantastic colleagues. So I think it's a little bit of the academic mix, a little bit of the regional and international referral mix from the Memorial Hermann system that makes our practice pattern somewhat unique. So to kind of say why spine, spine tumor boards tend to be very rare throughout the country. Many institutions may have a general tumor board, which, has become more and more common when caring for oncology-related patients. But in many general tumor boards, patients with metastatic spine tumors or primary spine tumors are not even presented. I think there's even a smaller group of CNS or neuro-focused tumor boards throughout the country. Many institutions have those, as well as certainly tertiary or academic referral centers that deal with cancer patients. But even within those tumor boards, it's very rare to discuss cases that affect primarily the spinal column, whether those are primary or metastatic patients. So I think one of the unique things, just given the volume that's seen within the Memorial Hermann system and the unique challenges of patients who may live hundreds, if not thousands of miles from the hospital where they're receiving their care, prompted us to get all the interesting parties together to really kind of move forward with how we care for spine patients, both at the Memorial Hermann and Texas Medical Center, but also across the country. We want a lot of what we do to impact spine care, everywhere. And that's partially through our tumor board. It's partially through great organizations like STS, which Ran is a founding member of. But we're looking to advance the care for these patients, which I think lags a little bit behind other diseases.
And I think you hit the nail on the head too with multidisciplinary approach. You mentioned that people who are listening to this didn't see me pointing to myself, because I had the pleasure of working with both of these two fantastic colleagues for many years when I was at UT and went out, interventional radiology, rad-onc, surgery, oncology, very important to treat and manage these patients. And while talking about that, these are very difficult tumors to manage. And so being where I am now, it's managed sometimes by general orthopedic surgeons, sometimes by neurosurgeons. But Ran, you do something a little bit different. And can you tell us a little bit about what's different and what your subspecialization does for these patients?
I think that taking care of patients with tumors or with cancer is not the same. Unlike what the typical notion of a surgeon, where you have a problem, you fix it, and you forget about the patient. If the patient can sleep during this process, it's even better. Oncology is not the same. The patient comes with baggage.
It's broke, we fix it, we're good.
Exactly.
Okay.
And the patient comes with a baggage of problems. And to echo a little bit what Mark was alluding to is our multidisciplinary approach. We put the patient in the center, and it's not just a phrase. The patient is in the center. There's so many other things that are involved in managing the care of the patient. And as you were saying, we have so many subspecialties. Just navigating between those different things, the process of taking care of a tumor, starting from diagnosis, getting the biopsy, understanding what that means, connecting with medical oncology, then planning a surgery, what type of surgery if needed, and then radiation. Just navigating this process is so overwhelming to the patient. And so we actually have a navigator that helps us with that, and a phenomenal person that actually takes the patient by their hand and then goes through all this process. I think that surgically speaking, taking care of spine tumor, you can be a surgeon that takes care of oncology, or you can be an oncologist that takes care of spine problems. And that's a huge difference. And I think that we try now to be more of an oncologist taking care of spine problems rather than a surgeon then is fixing a tumor or fixing a problem in the spine. And the difference is the mindset. We're thinking of not only how to make or manage the here and now problem, How do we allow Dr. Amsbaugh to deliver the best treatment that is possible? How do we allow our medical oncologist colleagues to deliver everything we can? How do we coordinate all of those things? And it requires understanding the tumor, understanding the needs of the radiation oncologist, the needs of the medical systemic treatment. How do we utilize interventional radiology? How can that help? How can we make them work with us and for the patient? It requires a constant learning and constant development and communication, which is unique, I think, within our group.
And I can imagine that the surgeries you do greatly affect the timing of radiation as well as giving chemotherapeutics because of time to heal. And so doesn't it take like 6 to 8 weeks to heal from surgery?
I love that question. It's just the biggest passion. And you were kind of asking before, what are we doing different? And we use our other, baggage of expertise to take care of tumors. And the fact that we do take care of other spine problems in a minimally invasive fashion allows us to take care of tumors maybe in a similar fashion. So in the past, we used to do huge surgeries that would delay the treatment of the systemic treatment, the chemotherapy, the immunotherapy, and the radiation. We now are able to use minimal invasive techniques, various techniques with endoscopic surgery, with the tubes, with microscopes, with ablation options to allow a more condensed treatment where we do an intervention, but we start the systemic treatment as soon as possible. And so often we are able to restart or take care of the whole disease way earlier and sooner by using different techniques that were used in the past. And I'm very happy that we are at the leading edge of that these days.
Yeah, some of your surgical techniques, if I remember right, they can restart within, at times, 3 weeks, restart chemo, correct?
I think our record now is 4 days. We were treating with minimally invasive tumor separation surgery using a very small incision. And we got the patient to start radiation 4 days after the surgery, including systemic treatment. That's a game changer in my mind.
No, it's massive because it allows for everybody to participate in the care of the patient to actually be getting the best of everybody in the field in a timely fashion, where in the past, I think there were barriers due to healing time, or time, for counts to come back as well. So this is really incredible. For people who are starting up, spinal tumors, how do these referrals happen? Do they come directly to rad-onc? I would imagine a lot of metastatic disease would go directly to rad-onc. Do they come to surgery? And what are your first steps in workup?
Yeah, I would say that that's a great question, Alexa. I mean, the part of the reason for the multidisciplinary approach, part of the reason for needing a navigator throughout this process, and one of the things that we think makes the program at Memorial Hermann special is that these patients come from everywhere. It is not a single referral chain into the program because spinal tumors are so common in metastatic disease that they really affect patients, and the impact on patients is so varied. So there are patients with asymptomatic spinal tumors that may be detected on routine imaging that's being done by a medical oncologist or a radiation oncologist during the course of a workup. There are patients who have profound neurologic impact of spinal tumors that may not even know they have cancer yet. It may be the diagnostic presenting symptoms. So you can imagine that the needs and, ultimately referral chains for these patients, who we need to get involved from a physician standpoint, from a supportive care standpoint, from a physical medicine and rehabilitation standpoint, are quite different amongst these patients. So I think, that's one of the things that makes the care of spine tumors so complex. And I think it's been one of the challenges, honestly, in the field of spine oncology in the past, because it's been very easy to look past those complexities in the past and say, we're just not going to deal with that. The patient will figure it out, right? And it's often very difficult for patients to figure it out in those situations. So it's quite a diverse patient population, and every patient is just a little bit different. I think Ran and I have kind of found over our time of doing this that, although many patients are similar, they're each individual patients, and they each have individual challenges. And even several years into the development of the program, every week that goes by, we find something new to kind of improve or change for patients. So it's been really rewarding in that situation.
And completely forgot for me, the involvement of PM&R so that people can get hooked up with rehab or physical therapy or OT or all the things that come afterwards, and how important it is actually to have the nurse navigator you guys were talking about to help walk patients through this, because they already have enough to deal with.
Yeah. And I think, we've been really spoiled within our program at Memorial Hermann. We, of course, have, when you think of the care of spine tumor patients, you think of, radiation oncology, neurosurgery, orthopedic surgery, interventional radiology. Those are really kind of, I would say, the frontline fields that deal with these patients. But there are so many other physicians that are, so important in the care of these patients. And I think we've been really lucky with the Memorial Hermann Tier Institute in having some of the best physical medicine and rehabilitation capabilities, both on the physician side and the staff side in the world, to help care for these patients, often with, quite significant cancer rehabilitation needs.
We're mentioning so many disciplines that are involved in the care, and shocking as it is, taking care of spine tumors is a humbling experience. And so, surgeons and radiation oncologists and interventional radiologists, despite the fact that ego is never a problem, we actually gave up on that. And we keep our ego and we use it elsewhere. And we checked that out at the entrance to the spine tumor board or the spine clinic. And we, again, it is amazing to see how we were able to work together without that hump on our back. And it is difficult. It's proving itself, because once we use all the disciplines and everyone with his own or her own expertise contributes so much to the care of the patients, and then you realize you can't do this by yourself. The days that we always say that the days that you had one giant physician, whether it's surgeon or radiation oncologist or medical oncologist, that took care of everything and was able to save you, those days are gone. I'm not sure they were even ever really true. I mean, the reason we are having such great successes is because we are not using that. We are actually using everybody on the team, and everybody has a lot to contribute.
It's really beautiful what you just said, making sure that we put the patient at the center of everything. I think in this world where things have changed a lot in medicine and we're tugged in a bunch of different directions, and I will mention, RVU models and things like that and putting pressures, but the important thing is the patient. It is always the patient. It is why we got into medicine. And I think for self-sustenance as well as for best treatment, could not have said it better myself. Everybody playing together as a team, putting egos aside and offering different perspectives from different backgrounds of training really does lead to the best, most complete patient care.
Yeah, I'll say two things about that, Alexa. I think that, people often ask when we go to conferences or, talk about our program, what's the secret to success? And I think some of that is the support and navigation. But I think the other piece of that is it's very, the field of spine oncology is changing, both on the surgery side, both on the radiation side, the interventional side, which, you tell us all about, all the time. And I think that it's for the general practice radiation oncologist, the general practice surgeon, the general practice interventional radiologist, they probably don't have a great understanding of what the latest technological developments in the field are. So, I think it's complex to delve. For me as a radiation oncologist, it's really kind of out of my comfort zone and complex to dive into the various surgical techniques. But through collaborative learning and speaking to our surgeons and learning and discussing cases, we find out more about the surgical techniques and what's possible. And, we kind of think of it's not just minimally invasive or maximally invasive surgery. There are very many subtleties to the techniques that allow us to collaborate. And I think it's that understanding of what we each do. The surgeons understand more of how the radiation is delivered. We understand more of the novel approaches through IR. We understand more of the limitations and benefits of certain types of surgical approaches. And not that one physician will prescribe a treatment and say, I want you to do this kind of surgery or I want you to do this kind of radiation. But by that collaborative understanding, I think we're able to make shared decision-making with the patient a lot better, because we don't feel like I have to solve this problem all myself. I think that spine oncology presents some of the most humbling cases that an oncologist can deal with, because there are so many issues that can go into managing these patients. And I think, as physicians, many of us try to kind of take the problem and solve it, right? And I think that by understanding how we can approach this as a joint team, and that trust that develops in understanding, like, yes, I don't have to do this. I trust that this surgical technique, or I trust that this interventional technique can solve this part of the problem, and then I can focus on, another part of the problem that maybe the technique of radiosurgery or radiation can address, has really been something that helps in the care of these patients. And we've seen greatly improved outcomes because of that.
It's beautifully said. And with that, kind of good segue into talking about the treatment of these patients. I know a lot of times they'll get their imaging, they'll come to IR, which I will press on my IRs that these are very, very important biopsies, very important to talk to your colleagues in rad onc as well as in surgery to know what type of tumor is suspected. If it's going into the spinal column, are you afraid if it's an RCC that you're going to cause an epidural hematoma? You probably need to think about your approach to that and make sure that you have a nice collaborative relationship and backup for that. Do they need preoperative embolization, which I will let Dr. Lador touch on about how that actually can affect his bleeding risk in treatments. But let's start with surgical treatments, and then we'll talk about radiation oncology treatments for these patients. So, Rand, when is it right to get a surgeon dedicated to spinal oncology involved? And what options do you offer for these patients in terms of surgery based on tumor characteristics?
Dr. Gonzalez said that treating spine tumors is a very humbling experience, and that's spot on. These tumors are so different in the way they behave, the way they are approached. Different tumors require different methods of taking care of, and once you realize where this is going to bite you, you realize what you need to deal with that. And so some tumors are very vascular, and they will create a major risk of hematoma and bleeding intra-op, or even before that. And so you will need you guys, Alexa, and to block that and to allow that. And by controlling those risks, you are able to utilize whatever tools you have to take care of that tumor. If I have less bleeding or minimal bleeding, I can think of coming in with an endoscope or with a microscope with a very small incision, because it's not going to fill my field with blood. Having said that, if I don't have that, I need to be ready for major surgery, major blood loss, massive transfusions. That all affect the patient, the outcome, the complications. We tailor our treatment based on a tumor, and different tumors respond differently to the systemic treatments. And so what we now do is, despite the fact that over the course of the years, it started by finding a friend that I can trust and appreciate, and starting work together. And then that friend eventually was able to dumb it down to the surgery level to explain what he's doing. And now I know that if he can zap something, and I'm literally saying that, if he can zap something, I need to allow that. And if he cannot zap that, I need to do something better to allow that. And so we talk, and he tells me what he can do and what I need to do to allow him to do a better job, or the best job that he can. And then we tailor the treatment. And the treatment can be starting from just giving him enough space to do his work, or to the farthest end of it, I need to take the entire tumor out. And sometimes if it's a primary tumor, maybe I need to take the entire tumor all in one piece as an en bloc resection, whereas we basically provide cure to the patient, hopefully. And so all these things come into play when we plan a surgery, and we use everything in our toolbox. And I was just thinking the other day, how many tools do we have here to take care of these tumors? And I'm looking at, the advances in maximal invasive and minimal invasive, and navigation and reconstruction and endoscopic surgery and microscopic surgery. And all of these tools, we can never do that without that collaboration and development. And so when a patient comes, to your question, I know it's a long answer, but when the patient comes and gets a tumor, then it's the start of the game. And then we start talking about, okay, what's our short term, what's our medium term, what's our long plan for this patient? And we set up a plan. And that plan starts with finding what it is, making a plan on how we take care of that. Stopping the bleeding is always so nice, and you know this. And we can plead and then you say and coordinate everything. But it's not just that. Sometimes it's even demonstrating vital structures. Can we approach from one side or the other side? Is it safe to do that? You guys allow us to do that by demonstrating vital structures that if we sacrifice them, then it's not a good day. And so, such as feeding vessels, feeding arteries to the spinal cord or to the brain. And so, based on that, we kind of, after gathering all the data, we form a plan and we hopefully execute it to the best of what we can. And then that's the fun part. Then we throw everything to Dr. Amsbaugh and say, fix it. And then he does his thing. And we keep on monitoring those patients. This is never fire and forget. It's always constant review and constant learning. And the number of cases that I remember sitting in tumor boards and we thought we had a plan, and then you come up and then say, well, I can freeze it. I can do some things. And I say, I didn't know we can do that. Let's do that. And so it's a very humbling experience. And I hate that.
I will say too, just talking, and I'm laughing just because I've had the pleasure of working with you guys, and you guys are both so amazing at what you do. And I set up this talk and let's talk about surgical. Let's talk about rad onc. And I loved how you're like, well, I can't really separate these because they're so intertwined. And that's so important. I mean, I think I've learned so much from you guys. I mean, sure, I can cryo and freeze and embolize, but the fact that I don't even think it really clicked to me that my preoperative angiography also shows you so much before surgery. So you can do that. And even the thought too of you may not need to get everything out, but you can get enough out because, and I'll let Mark talk about this, it affects his radiation dose and how you can do surgery and radiation together to get the best outcome for the patient and how intertwined all of these approaches really are.
Yeah, I mean, absolutely. I think, I think gone are the days that we can talk about one modality, whether that's an interventional modality, a radiotherapy modality, or a surgical modality, independent of the other things that can be bring to the table. I mean, if you truly review a chart and say, how many patients have gotten an interventional approach and radiation, or a surgical approach and radiation, or maybe all three, or, it's very many patients. I would say very few patients these days are treated with kind of a monotherapy approach locally. That being said, I maybe it is time in the podcast, I'm not sure, to admit that local therapy, which is what all three of us do, right, is perhaps the most important and the least important in some ways to the care of patients with metastatic spine tumors, right? So taking away the primary tumors for a moment, these patients, the majority of patients, have some form of metastatic carcinoma. There are, of course, other malignancies that we treat, but the vast majority of patients in spine oncology have a metastatic carcinoma. And of course, systemic therapy has been and continues to be really the most important care for those patients. And I think it is a testament in some ways to the advances in systemic therapy that we can even have a nuanced discussion about the differences in local therapy in spine oncology, because there was a long period of time where local therapy did not matter because the survival of patients was very short after the development of spinal column metastases. However, with the development of novel systemic therapy agents and specifically immunotherapeutic agents in many disease sites, survival has increased quite significantly in these patients. And I think the spine oncology program has really been a recognition of the fact that, if a patient is in incredible pain or incredible neurologic compromise, they cannot go and get the systemic therapy that will ultimately prolong their life. And in addition to that, if patients are living longer and longer and longer, functional outcomes that may have been acceptable in a patient with a survival of 3 months are no longer seen as acceptable in patients that may have survival of 3 years or longer from the time that they presented. So I think that's required us to look a lot more at our outcomes. And I know that's a long-winded way of saying essentially what has happened in radiation therapy, which is that we've had this technology that was great for patients that lived 3 months or 6 months. And as patients lived longer and longer and longer, we've found out, I think most spine oncologist-focused radiation oncologists would say, we found out maybe that's not as good of a technology for patients who may live 3 years or 5 years, down the line. So we've gone from a relatively straightforward treatment of conventional palliative external beam radiation therapy, which is safe to deliver to very large segments of the spine in very sick patients, to more of a nuanced approach with stereotactic radiosurgical techniques, which I think has necessitated a higher understanding of interventional techniques and surgical techniques, because there are problems that just can't be solved with stereotactic radiosurgery that need either interventional techniques such as vertebral augmentation or ablation, or surgical techniques such as stabilization or tumoral resection or vertebral column support. And that's really caused us as radiation oncologists to start thinking about how to stratify these patients between techniques. And I think although systemic therapy does not often play a role in the local treatment that we give, it is very important to understand the patient's options from a systemic therapy, because that may indicate how aggressive or not aggressive we need to be, how, if we're going to go for surgical techniques that may delay the care systemic therapy for some period of time, how necessary is it to undergo those techniques? And I think we've had a great time working with our medical oncologists as well that partner with the program to better understand what they have to give.
Something else I want to touch on is your talk about the role of kyphoplasty, vertebroplasty. And Rand had also brought up sometimes debulking posteriorly the tumor. I'm very fortunate to have learned so much from you, Mark, about radiation treatment, and maybe why I shouldn't just throw probes in RFA, balloon certain tumors, and how that might affect treatment, because the goal is always, as we've always talked about, is we want to leave everything on the table. And so do you mind just touching on briefly, to those who may not be as privy to what you do, about the effects of a tumor that involves the entire spinal, vertebral body as going posteriorly, and why that may be a patient that you should see or consider seeing first, or Dr. Lador should posteriorly debulk first, and how that affects your treatment?
Yeah, I'll just speak about vertebral augmentation for a moment. I think personally my journey with vertebral augmentation has been from, really not understanding it and not thinking it was an important part of care of many patients, to really seeing the successes of vertebral augmentation in the care of our patients, and now it being an integral part of care for many patients. And I think that's really, Alexa, because, vertebral augmentation and radiation techniques, especially stereotactic radiosurgery, tend to be a marriage that can help each other out so much. And that's really because the most common side effect of stereotactic radiosurgical techniques, especially as we use single fraction high dose stereotactic radiosurgical techniques, is vertebral body fracture, right? We know that that's an increased risk with single fraction. We also know disease control is better with single fraction high dose stereotactic radiosurgery. So how can we help that situations where there's fracture, maybe not fracture that's unstable now or necessitates a surgical procedure for fixation, and still deliver a appropriate radiosurgical plan? And vertebral augmentation has helped out so many of our patients in that situation. I think likewise, vertebral augmentation is a great procedure for stability, but I think as a monotherapy for disease control, it is really inappropriate in 2025 to consider vertebral augmentation as the only therapy for local disease control.
Agreed.
And so I think that is really, allowed stereotactic radiosurgery and, the various procedures, whether that's ablation, whether it's kyphoplasty, whether it's for other types of vertebral augmentation like spine jack or other local procedures, to really work together well when larger surgery or, more complete surgery is not indicated, when Rand doesn't think that is something that needs to be done in those cases.
And for my colleagues, just real important to know, is, and something I didn't think about until I was educated, was that if you want to do an ablation and do an RF, okay, but how do you know you actually get the whole tumor? And then you're going to put balloons up, and then you're going to cement. And cement doesn't prevent future interventions, but pushing the tumor posteriorly does, because that limits your radiation oncologist dose, because they're trying to dose, and correct me if I'm wrong, again, I'm speaking in terms of zapping as well. You can't zap as close to the spinal column, correct? So you have to grade your what you do, and we could potentially take a treatment off the table by not involving radiation oncologists sooner.
Yeah, I think one easy way to kind of think about at least radiosurgery is, conventional in the era of the 1970s, conventional radiotherapy techniques were given using a beam arrangement that was usually a single posterior beam or potentially a posterior beam and an anterior beam, meaning that everything in, perhaps a several centimeter wide segment would be treated to the same dose throughout the body. So those doses were developed as safe to both the spinal cord and the bowel and the GI luminal structures. So because those structures could not necessarily be avoided in the delivery of radiotherapy, the doses were overall lowered, and a technique of fractionation allowing for normal tissue repair was taken. And this was the standard of radiation, and even the standard today. We use this technique very often in the treatment of patients. But as we've sought to escalate the biologic effective dose of the radiation treatment to provide perhaps better local control and perhaps better pain control, and in some initial studies, perhaps that local control leads to better survival of these patients, we've had to escalate the dose past what is commonly known as the spinal cord and GI luminal structure tolerance. So the only way that we can successfully go to a higher biologic effective dose while treating the same area is to avoid the GI luminal structures in spinal cord. So modern radiation techniques have improved to allow us to have very, very sharp dose gradients, meaning that the dose can fall off very rapidly over the course of several millimeters between a very high dose region and get the dose down safe enough to those structures such as the esophagus, the bowel, or the spinal cord. The closer that target, the closer the area at risk is to those structures, the more challenging our job is to effectively give the minimum dose that we know has a likelihood to control the tumor and not exceed the maximum dose that would lead to an unacceptable risk of toxicity to the spinal cord or to a GI luminal structure such as the esophagus. So it has become a game of geography, and a couple millimeters makes a big difference in our world. So exactly what you're saying, if we have an area that is 4 millimeters away, but then a procedure has caused the area at risk to become 1 millimeter away, or even abutting a structure, that may not seem like much. We're talking about 3 millimeters, 4 millimeters, but that could dramatically change the options that we could potentially offer a patient. And so it is important to kind of understand what is the overall treatment approach? How can we make that better? How can we make that worse? And let's, kind of address that as a multidisciplinary team.
In line with that, we have changed so much over the years by avoiding procedures that may affect the future or the need for radiation, but also changing our procedures to allow a better visualization, a better ability to create or provide those radiation. And it's almost like a tennis table going back and forth. So radiation was at first very conventional and very unidirectional. And so we were doing surgeries that were appropriate for that. All of a sudden, Dr. Amsbaugh and his colleagues developed this fancy technique, and now they're ablating everything and they can kill the tumor. And now we need to address that. We need to give them that 1 to 3 millimeters of that space. So we can do that. And then Dr. Amsbaugh now is becoming spoiled. And then he says, I need to see the spinal cord. Now I want to see the spinal cord because I want to be very safe. And then I didn't say that, but a lot of, radiation oncologists are very risk averse. And so he does not want to create any damage. So now it goes back to our field. And now we need to kind of allow them to see better. And so there are techniques to do that, either through non-fusion options, so basically taking the tumor away without placing any instruments, or maybe using radiolucent instruments that we now have available, which is a phenomenal way of, getting the best of all worlds. And then so we do that, and then we can still see the tumor, still deliver the safe radiation. And I'm sure this is going to go back and forth so many times, because the more we do, we can just never satisfy those guys. And they just need more, and we need to get better at that, which is great, because that makes us all better. And so we are very careful with the kyphoplasty, as you were saying. We are very careful not to create any damage while utilizing the huge advantage of cement augmentations and RF ablation and anything that improves the quality of the life of a patient, because that's at the end of the game, and at the end of the day, that's our purpose, to make sure that the patients are having longer life, but also a better quality of life. And so we constantly evolve and change our practice based on that.
And I think that's a good segue to talking about pain management in these patients, because a lot of times these patients, at least what I see, they may have something that's compressing the spinal cord, requires radiosurgery, requires some surgical repair, requires some embolization and treatment because of spinal cord compression, but some of it is treating pain and managing pain. And so how do you guys do that? Opioid pandemic, obviously, I'm the first person who does interventional pain that says there is a role for opioids in oncology. I think there will always be a role. But with all these new surgeries we can do to help with pain, radiation to help with pain, for myself, nerve blocks and cryoablation, this multidisciplinary approach to pain, how do you guys approach pain? Or is it just, as I said, multidisciplinary and trying to find out the new therapies and see what helps?
So let's define pain. That's a huge initiative that the AEO, Spine Knowledge Forum, are now in the process of defining. What is pain? Is it pain coming from mechanical instability? Is it pain because of the tumor burden? Is it pain because the tumor is pressing on nerves? Those are completely different types of pain. And by understanding what is the pain, what is causing the patient to suffer from his or her tumor, then we can address the pain. And so if the pain is mechanical, that's on us to fix that. And we can use cement augmentation to the least, or we can use even percutaneous fixation, and can use instrumentation and fusion and all those things to stabilize the spine. But if the pain is oncology related, basically the tumor burden, the tumor can be painful, then we need to control the tumor. And then I cannot do that with any surgical or knife or scalpel or whatnot. And then it's our other methods that Dr. Amsbaugh may probably elaborate way more. And so I think the first step is defining what is causing the pain. It's not as easy. Sometimes it's a little bit of everything. But then once we do that, then we use everything that we can.
Yeah, I mean, pain is a huge problem. I mean, pain is a problem for most patients with spine oncology to some degree. We do like to think about things in terms of mechanical or stability related pain versus local oncologic pain. And then there's kind of a broader burden of metastatic cancer related pain. Obviously, I call you, Alexa, and you, Ran, if there is any problem with structural or mechanical type pain, because radiation typically does not improve that. For oncologic or biologic pain caused by the tumor itself, first line therapy would be pharmaceutical therapy. I think opiates play a huge role in these patients. I think that the modern approach we typically use is a multimodal anesthesia approach. So just monotherapy with opioids, I think, is becoming largely inappropriate in the modern understanding of how to treat these patients. Multimodal analgesia is really important, including neuromodulating agents like Lyrica and gabapentin, other ways to affect pain, but opioids will be a pretty large proportion of that. But there can also be local pain strategies with radiation therapy that help. We know that external beam, even conventionally fractionated single fraction external beam radiotherapy treatments, which is very low burden for the patient in terms of having to come for treatments or other things like that, are incredibly effective in helping oncologic pain. That being said, we're now understanding that for patients with limited areas of tumor that are causing pain, stereotactic radiosurgical approaches can offer better pain response as well as complete pain response. And there are now trials looking at randomizing patients between conventional fractionated radiotherapy approaches and stereotactic approaches, which have demonstrated that the pain control is greater with these. So we try to fit overall pain management strategy with radiation to the patient, their other needs, and everything that's going out. But I think it's always a multimodal approach.
And if we can also touch on the effects of radiation on the actual nerves, I recently reached out to you about this. Whenever you have, often with these patients, the tumor investing in the neuroforamen and exiting it, sometimes if the patient is non-mobile, having severe, true neuropathic pain, can go in there with some cryoprobes, but obviously cannot tease out motor or sensory. So for some people, they're not motor or not mobile, no problem. Cryoablating those areas within 3 to 4 months of intense physical therapy, the axons will regrow. Hopefully we got them more mobile. They get on their chemotherapy and they can be mobile again. But you can also do some radiation for this. So at what dose can you do radiation that is safe on nerves and you have that Sunderland 2 type injury or not? I think it's something very important to touch on, very fringy and edgy, but I think also very important to discuss.
Yeah, so I think, obviously there is a burgeoning interest in radiation, effect on pain control, right? So for outside of the spinal column, but in the cranial nerves, for many, many years, high doses of ablative radiation have been used on the order of 85 gray to 90 gray in a single fraction targeted at the trigeminal nerve to help with trigeminal neuralgia. And there's a huge body of literature that has suspected that there is modulation of the pain response for the trigeminal nerve in patients with trigeminal neuralgia, specifically classical trigeminal neuralgia. Those doses are unable to be delivered to motor nerves and unable to be delivered in the spinal column because of localization technology. So that's not something we do in spine. There was interestingly an Israeli phase 1 study that was done targeting lumbosacral and I think it was the celiac plexus nerves using stereotactic radiosurgery approaches, not targeted towards a tumor, but targeted just to the neural plexus. And that showed dramatic pain response in those patients as part of the phase 1, phase 2 study that was done. That's very early on to show that radiation targeting nerves can modulate the pain, but still investigational. By far, the way that we affect pain in patients with metastatic cancer is by affecting the tumor. So it is more an effect on tumoral compression than the nerve when it comes to spine treatments of radiation treatment. So if a exiting nerve root is being compressed, which is generating a pain response in a metastatic carcinoma patient, radiation can be incredibly effective in those patients, but it's by decreasing the size and pressure from the tumor itself, not necessarily modulating the nerve, even at the stereotactic doses that we use. I do try to separate that in my practice from patients who may have nerve damage to that nerve, where even if the tumoral pressure was relieved from that nerve, that would not fix the pain response. And I don't think radiotherapy is as helpful in those situations, just because, as I was saying, we can't escalate the doses in that area to the doses that we know are helpful.
Okay, thank you for sharing that. This has been such an incredible discussion, multidisciplinary, complex patient, complex group. Any final thoughts from either of you guys on the futures on spinal oncology, and final thoughts to leave for colleagues or referring providers?
I think that the future is bright. I think that the days that we needed to compromise, we needed to kind of choose between life and function should be behind us. In the past, we used to prefer or think whether we need to control systemically and then give immediate systemic treatment to save the patient's life while giving up on some neurological function, or should we treat the neurology, basically protect the nerves and protect the function of the patient, but delaying the systemic treatment and risking the patient's life? And it was always a huge battle between the disciplines. And we were always revolving around that and trying to kind of maximize the treatments on each one of those directions. And I think that nowadays, with the newer techniques, we need to kind of rethink that, and we need to change the mindset. Maybe we can get the best of all worlds. Maybe we can tackle the neurology, protect the patient while starting systemic treatment very fast. And to do that, we need to use every tool in our box and in our toolbox. And we need to think outside the box and get all capabilities. And our colleagues in other places, they have laser ablation, and we have endoscopic surgery, and we have minimally invasive surgery, and we have other ways with radiation to treat the tumors and to protect the nerves and to control the pain while not giving up on the systemic. And that opens a broad array of capabilities and options. I think we're on the verge of changing the game. And this is exciting times. You can see how excited I am. These are exciting times. I think we are at the verge of actually changing the way we treat spinal oncology.
Yeah, I agree. I mean, I think it feels like we're at a precipice looking over a valley of the future, right? I mean, it feels like a time that spine oncology is finally becoming more and more recognized and more important to patients. I think happily, what we do will become less important as our medical oncologist continues to make advances. I don't think anybody's going to be happier about that than all of us. But the reality is patients still need local support and treatment to facilitate these options. And I think, the trials that have shown that, and there have been many across many disciplines, that local care impacts the overall systemic outcomes of these patients are really important and validate kind of what we do. So I look forward to the technological advancements. Medicine will continue to march forward, including everything that the three of us do. But I think a successful program continues to put the patient at the center and realize that no matter the technological advancements, as long as the patient is part of the decision-making team, that we do our best for these patients, that, we'll continue to march forward with progress.
Doctors Amsbaugh and Lador, thank you so much for being here with me today. University of Texas physicians, Memorial Hermann, I hope they realize how lucky they are to have such two dedicated physicians putting the patient at the center of their care and moving the field forward. And I think we can all learn from this. And I am very proud to call you guys my forever colleagues. Thank you for being here today with me.
Thanks a lot.
Thank you, Pablo. Thank you.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.